his current update on the diagnosis and management of pulmonary hypertension. Excellent topic, excellent speaker. Thank you, Doctor.
Thank you. Thank you
Go
very
ahead.
much. I would like to thank I think this is my last, the previous version. Can you get the version which was last night, yesterday? This is not the version I gave it to you yesterday.
अरे गड़बड़ आता थी काट लिया है फिर आगे
Recycle bin में भी
I deleted now that's a problem
इधर भी ऑर्गेनाइजेशन
Though this one is very short, so it's making it easy for the all right. Being talked at the end of the session of the conference is really, but thank you very much for staying until now. Yeah, thank you very much. And I believe there is also virtually someone there. So it's my task today just to talk about how you diagnose pulmonary hypertension and how to initiate the treatment of.
is this one yeah this is the one COVID guidelines 1 second
And can you start slide whatever resolution?
not this one what's it I don't think I have it freaking hell yeah, this is the one which is given to me today
कल का बोल रहे हैं
कल वाला डिलीट किया था मैंने shit no, I don't have that now
इसमें देख
one more here it is yes one should be in this one from here yeah I'll open it from here only
We can put banner.
banner
it's the same one right
this one
Yes, this. Thank you. All right. So start by definition of pulmonary hypertension, and this definition actually is the latest definition on 6 World Symposium. pH is a hemodynamic definition. pH is being defined as an increase in pulmonary pressure that 20 or more at rest, and that is assessed by right heart catheterization, is not by echo. And if you go in more details about it, that is the mean in arterial hypertension, that the pressure more than 20 or more, plus the pressure is less than 15, plus PVR 3 or more. So that is, we call it pulmonary arterial hypertension. Whereas pulmonary venous hypertension, the mean pressure again is 20 or more, plus which pressure is more than 15, but PVR is less than 3 Woods. So we call this pre-capillary, and that one we call it post-capillary. And we see more details about post-capillaries, which is very debatable and possibly the most common pulmonary hypertension. That is in patients with left heart disease, they call it isolated post-capillary, when the mean pulmonary pressure is 20 or more, plus PVR is less than 3, and which pressure is more than 15. Whereas combined post and pre-capillary pH, the mean pulmonary pressure is 20 or more, PVR is more than 3, and which pressure is again is more than 15 as a post-capillary. The classification of pH remains same for quite long time. Since 1992, that is first, group 1 is pulmonary arterial hypertension, group 2 is pulmonary venous hypertension, which is related to left ventricular dysfunction, and group 3 is related to lung disease or hypoxia. Group 4 is chronic embolic disease or something similar to anything obstructing pulmonary arteries. And the last one, as pulmonary hypertension with unclear or multifactorial mechanism where we don't have many, and I call this one is junk box. In details of each of these pulmonary hypertension, I think you may go in detail. This is available, and the group 1, which is more we concern, and group 4. So that is group 1 is including idiopathic irritable familial, plus associated with conditions such as connective tissue disease, HIV, portal hypertension, congenital heart disease, which is not considered as in group 2. And group 2 is actually the pulmonary hypertension due to left heart disease, whatever the reason for either systolic or diastolic dysfunction, valvular disease, and others disease. And then when it comes to the lung, which is more for pulmonary, for physician or lung physician, pulmonary pulmonologist, we have either interstitial or COPD patient or any sleep disorder breathing, which is again group 4. I mentioned that CTEPH is possibly the commonest one. The other, it's rarely we see this patient, but we dealing with chronic thromboembolic pulmonary hypertension. As I said, group 5, which is multifactorial. We have possibly in Gulf, in particular in Oman, we have hematological disorder such as sickle cell and thalassemia, but myeloproliferative disorder is also common. Something changes, that is sarcoidosis and LAM, lymphangioliomyomatosis, currently is in group 5, but possibly sarcoidosis will move to group 3, which is possibly they move into lung diseases. So this is the algorithm we follow in pulmonary. This is based on 2015. It's not changed. And basically, this whole algorithm is passed through 3-4 steps. So you suspect, and then you detect, and then you confirm it, and then you characterize to start the treatment. So what's the suspect? Unfortunately, the symptoms, which is we use is non-specific symptoms, is unexplained dyspnea despite multiple diagnoses. And screening is another one. Screening of high-risk people like scleroderma, chronic liver diseases, patient who have family history, or some using stimulant anorexic. And many times actually we got it as an incidental finding in CT scan or echocardiography and so something else, and ECG. Being symptoms is actually non-specific, so we should screen always for patients who have in high risk. So we have a lot of patients have scleroderma, chronic liver disease, and others. So we need to screen these people. So screening is important. Once suspected, either by symptom, by screening, or by incidental finding, then you move to next step, which is an echocardiography. So echocardiography actually detecting pulmonary hypertension is not confirming pulmonary hypertension. So we should know that echocardiography is detecting pulmonary hypertension, but not confirming it, and should be performed whenever pulmonary hypertension is suspected or for screening. Echo is not sufficient to support specific treatment or decision. Cardiac catheterization is a must. So we shouldn't treat patients based on echocardiography. The right heart catheterization is important. So what is the rule of echo? Echo is examination is used to assign a level of probability of pulmonary hypertension. And then based on this probability, then we move for right heart catheterization. And this is the finding, this is based on. So we have actually the most important peak tricuspid regurgitation velocity. And this is mainly less than 2.8 or more than 3.4 in the presence or absence of other echo finding, which will be on the second slide. So if the patient having no symptoms and the velocity is less than 2, this is mild. If the patient having less than this, but there is other findings of presence of other echo finding, which I'm going to tell you on next slide, then this is intermediate. And if the patient having velocity more than 3, even you don't need other findings sufficiently to be in high probability. And this is the other finding other than velocity. So you look actually the relationship between right ventricle and left ventricle. So if that is in the right ventricle / left ventricle basal ratio is more than 1, or the eccentricity of left ventricle that is more than 1. The second one, look for pulmonary artery, the size of pulmonary arteries, the acceleration time is less than 115, either in systolic or mid-diastolic, or the patient have early diastolic pulmonary regurgitation velocity more than 2. The other things you look for inferior vena cava and right atrium, the size of right atrium, and the size of inferior vena cava, and that is the reduction of respiratory collapse less than 50 in sniffing or less than 20 in quiet. So this is important even in the absence of tricuspid regurgitation velocity. So once you have the presence of, no matter if you have this one, then you have to decide whether your patient will be in low or intermediate and high, and based on these, in addition to whether the patient having a risk factors or no risk factors. If so, the patient. So if the patient have no risk factors, i.e. means risk factor like chronic thromboembolic pulmonary hypertension, or patient have family history, then the only indication of right heart cath is only when the patient have high probability. Whereas a patient having some risk factors, as like scleroderma or connective tissue disease or chronic thromboembolic pulmonary hypertension, then right catheterization is actually required in intermediate and high probability. So before you move your patient to right catheterization, is very, very important to do or to consider left heart disease or lung disease, because as I said, this is the bulk of pulmonary hypertension. It's actually more than 80% of pulmonary hypertension is either related to left ventricular dysfunction or related to lung diseases. So it is very important to rule out by symptom, signs, risk factors, investigation by ECG, PFT, in particular DLC or chest X-ray or CT scan, and then if the patient is clear, either not left ventricular dysfunction or not patient unlikely to be lung disease, then you go ahead and do right heart cath. And unfortunately, ECG or a chest X-ray to start with is very subtle sign when in particular at the initial. But it is important to do an X-ray because you may see cardiomegaly, main prominent artery prominence, enlarged hilus. You get peripheral polycythemia or peripheral vessel reduction. And then it's important to know that is the degree of pulmonary hypertension may not reflect the severity of the disease. And also is important, a normal chest X-ray does not rule and exclude pulmonary hypertension. And more importantly, it's good to do chest X-ray maybe because you may rule out or rule in lung diseases in this case. ECG, unfortunately, again, ECG provides supportive evidence, but not a normal ECG. But normal ECG does not rule out pulmonary hypertension. In severe cases, you may get right ventricular hypertrophy, right atrial enlargement, right axillary deviation, RVP, but that is in severe cases. If you get that patient, it must be having right ventricular hypertrophy is insufficient in diagnostically or specifically, not sensitive, not specific. So, and that's why ECG is not good screening tool for pulmonary hypertension. So pulmonary function test, as I said, is important to rule out whether this is your patient obstructive or restrictive lung disease. But again, that DLCO even significantly reduced in scleroderma patient, i.e. even with hypertension, and that should be also integrated with detect algorithm for patient with pulmonary hypertension. I will go quickly to CT scan, HRCT, and CT angiography is very, very important, especially for chest physician. So easy to appreciate when the patient have air trapping in case of a small airway disease, bronchiectasis, and with air trapping, interstitial lung disease. It's also emphysema patient, and PVOD. Yeah, veno-occlusive disease is you can diagnose actually by CT scan because it is in group 1. And you can misleading you as right heart cath, but a good interpretation of CT scan is important. CT angio is very important because sometimes incidentally you can get these findings, so you can proceed. So enlargement of an artery compared to aorta, which is supposed to be an equal in diameter, and you get a lot of collaterals. If you look at once you get these collaterals, no matter what other finding, you have to find out what exactly the cause for collaterals. Right atrial and right ventricular enlargement and flattening of the septum is important also finding in these. The contrast in the inferior vena cava is also indicate this patient have a severe tricuspid regurgitation. And it's important for CTAF, obviously, and you see eccentrical PE, And also you can see some whips or rings that is indicate the patient have a chronic C. So once you do that, then VQ scan is important. VQ scan is important because should be performed in all patients because it is the method of choice to rule out or rule in chronic thromboembolic, in particular when it is more subsegmental. So CT pulmonary angio, you can miss that one. A normal or low probability in VQ scan exclude CTAF. And VQ scan usually normal in PH, but sometimes you may get peripheral unmatched non-segmental defect, but that is it. So if you look for a normal VQ scan, like me and you even some difficulty to know which one is perfusion and which one is ventilation, and that is the classic abnormal VQ scan. Patient with chronic thromboembolic pulmonary hypertension, you can see that is ventilation is normal. You recognize this ventilation because you can see tracing in the airways where this is perfusion, and you can see that is unmatched defect on that in chronic. So once you do that, then you go ahead and to do right heart cath. So it's important to rule out lung diseases and cardiac diseases before you go for right heart cath. Try to minimize the number of patients to go for right heart cath. So right heart cath is confirming pulmonary hypertension. So what is right heart cath? Is the gold standard to confirm a diagnosis of pulmonary hypertension, and should be performed after completion of other investigation, as I said, to reduce the number of patients is required to do. Right heart cath, as we know, as cardiologist is telling us, that is low morbidity and low mortality, so there is no worry about it. And what is the minimum required to get pressure in a certain in right atrium, right ventricle, pulmonary artery, and pulmonary wedge pressure, and then you get calculated PVR and cardiac index. And you should know that this pulmonary wedge pressure is a surrogate of left atrial pressure, so it assesses actually left ventricular function or dysfunction, and should be recorded at the three measurement, and you take the mean. All pressure measurement should be determined at the end of normal expiration. Saturation is important to see stepping up or stepping down, so you rule out or rule in shunt, intracardiac shunt, and it should be taken minimally, at least as to be superior vena cava, inferior vena cava, right atrium, right ventricle, and pulmonary artery. By doing this, you will know if there is shunt on the patient. The best for cardiac output to do thermodilution, but if you don't have thermodilution measurement, you can do direct fake method. Now, vasoreactive test is important. There is a certain group of patients in group 1 where you may get a responder to calcium channel blockers, and who is actually recommended only for idiopathic or hereditary or drug-induced pulmonary hypertension. And inhaled nitric oxide is the standard, but there is other material they use. We used in our country adenosine, but some people they do iprastenol, and some other, like Germany, use iloprost as alternative. And what's mean positive test or positive acute response is defined a reduction in the mean pulmonary pressure by 10 or more millimeter mercury, but these should be reduced to absolute value of less than 40 or less from the baseline, provide that cardiac output is either increased or unchanged. Now, before you start treatment, now you got the diagnosis, you have to characterize your patient. Characterization is important, is to know what type of patient in group 1 or group 4, whether the patient have connective tissue. And this is the test you have to do. You have to do connective tissue screening, you do HIV, you do liver function, and you may do angiography once you have certain this patient having chronic thromboembolic disease, and other 6-minute walk test and BMP is actually assess the severity. So then you need to assess a risk assessment. Once you get precise diagnosis of your patient, you need to get risk assessment. So risk assessment is very crucial because you have to know whether your patient have low risk, intermediate risk, or high risk, and based on these, you have to start treatment. So starting treatment after getting full diagnosis, then you have to do assessment. So in conclusion for this part is, once you get patient have suspicious patient, then you need to detect by echocardiography and then you need to do right heart cath. But before you do right heart cath, you need to rule out actually lung disease and heart disease or left ventricular dysfunction. You need to characterize your patient. You're getting the etiology of that is by doing connective tissue disease, HIV, liver function, and then ultrasound. And then you do risk assessment, as we said, mild, moderate to severe, which is 6-minute walk test, BMP, hemodynamics, echocardiography, and at the end you get treatment of the patient. So quickly, what is the treatment? So once you decide this patient to treat, then you need to assess the assessment of risk stratification. And basically they divide it to clinical evaluation, exercise capacity, and right ventricular function. So assessment, whether the patient have heart failure, whether the patient have syncope, or whether the patient, what is the functional class of the patient. Exercise capacity, commonly we do 6-minute walk test. Some research center, they do cardiopulmonary exercise test. I'm not doing it. And right ventricular, you can get it either hemodynamic from right heart, or BMP sufficiently to do that, but echo also, and EMR as well. You know, and it's very important to know whether your patient mild, moderate, and or intermediate and high risk. We always like the green zone, so that patient always on the green zone is better improvement. And in fact, this is, you see, you know, low risk profile as a baseline, and follow-up is important. So this is the survival or the mortality, and you can see the patient who have mild diseases either at the baseline and follow-up have a good survival. We tend not to do a lot of tests. In my clinic, I do functional class, 6-minute walk test, and pre BMP. But many people, they do a lot of other findings or indices. Now, risk assessment or risk stratification is very strong evidence to decide what type of treatment, and it is in the follow-up as well. Now, treatment goals, achievement and maintaining low risk, which is the green zone, and that is assessment is important for. So once you decide your patient to start medication, you have to go, a patient who have initially no treatment, naive patient, general measurement is important, and this is general. So this patient is actually should be measured, are important, avoiding pregnancy, anticoagulation in some group, mainly CTAF, immunization, oxygen when it is required, and obviously diuretics. So what is the available medication now? We have now 3 lines of medication. We have endothelium pathways, we have nitric oxide, and we have prostacyclin pathways. And under each, actually, we have approved drugs by FDA. We have bosentan, ambrisentan, and macitentan in this. And in regard of nitric oxide pathway, we have sildenafil, tadalafil, and there is, in 2014, riociguat, which is a little bit different working, but it is same line. And in regards of prostacyclin, we have ibuprostenol, which is approved, the first one among all of these in 1995. And we have treprostinil, and we have iloprost. Commonly, we use treprostinil and iloprost. And recently, selexibag, when I say recently, that is 2018, selexibag, which is an oral medication, which is receptors analog for prostacyclin. In 2020, there's another pathway, which is BMP-R2 modulator, which is sotatercept, which is not yet actually putting on the guidelines, but we hope this drug will help us. So currently, majority of patients either in 2 drugs or 3 drugs, but in near future, we may put our patient in fourth medication. And this is the path where you get it. So 1995, as I said, ibuprostenol is approved over years, and recently, just to late of 2020, sotatercept is approved as well. What usually we do, this is the evolution of pulmonary hypertension management over time. So we start initially by monotherapy and sequential combination therapy. But now we follow actually initial combination therapy. So majority of the patient with pulmonary hypertension, we start them as initial combination, unless it is a very small limited group, which I will show it to you. And then you do risk-oriented sequential triple combination. So we start by initial combination, and then we do risk-oriented sequential triple. It's not recommended to start upfront triple therapy, though we do sometimes in severe patients. But in fact, if you do initial combination and then risk assessment, you do that. So what is when we see this? This is the the mild initial residual rule of initial as a monotherapy. Now, as I said, monotherapy is not anymore used except in this group of patients when the patient have pH 75 years old with multiple risk factor for HFpEF or high probability of PVOD, HIV patient, portal hypertension, very mild diseases, combination therapy unavailable in your institute, then that is the patient where you start. In fact, this group of patients is very small group number in my cohort. But then you need to start and you can start any monotherapy, which is, I mentioned, that is approved. But we currently use actually oral medication. So either from for endothelium receptors or from phosphodiesterase inhibitor. That is what I used to do when I start as a monotherapy. I think my colleagues agreed on that. We don't actually start as a monotherapy a prostacyclin analog. Now, when we initiate as initial in moderate risk or high risk, we have to start dual medication as upfront, and you can choose any combination. This is more evidence-based, ambrisentan and tadalafil, but you can actually, this is not a drug effect, this is class effect, so you can use bosentan and sildenafil or whatever combination from those, but you can actually do whatever the combination you have. But if your patient is actually high risk, then it's important to start one of them from prostacyclin group in a combination. Now, when you decide to put your patient, as I said, you start initially by combination, by oral medication or whatever, dual medication. When you decide for triple sequential, then you add a third line of the treatment. Now, we are not allowed actually to do two patients in same class. We different classes. I mean, some people, they do riociguat is not allowed actually to add it to sildenafil or any other PDE5, which is, for example, other medication on that. We do riociguat as a switch to patient on sildenafil or tadalafil. But I have seen a new study from our colleagues in Turkey. They use riociguat in a patient who is using sildenafil. I don't think that is an evidence base. So we usually, if your patient is not responding to sildenafil or tadalafil, in addition to bosentan, for example, then you may switch your patient to riociguat.